Good afternoon. Welcome to the Senior Care Group. My name is John Freitag with Freitag Family Agency. I have Desiree Krager from Premier Home Care, Donna Daychuk with Rothkopf Elder Law, and our special guest today, Will Reiter from the AFD, and he has his Phillies red tie on.
There you
Celebrating the
go.
win.
Exactly why I wore that red tie. No, in fact, red is one of the colors of AFTD. So, but if I can support the Phillies at the same time, all the better. So
right.
it's really nice to join you, John and Desiree and Donna, and so much appreciate talking to the Senior Care Group. In fact, when I moved back to Philadelphia about 6 or 7 years ago, I networked at the Senior Care Group. I was looking for a job, and lo and behold, I found one. Not this one, not where I am now, but at actually the Alzheimer's Association in the Delaware Valley. So I know it's a great group of senior care professionals, and excited to be talking about FTD, a commonly misunderstood and misdiagnosed type of dementia. And I'm going to just say a little bit more about myself, and then I'll share my screen. So I actually started my training and working with older adults as a licensed music therapist. So in a lot of settings, and particularly people with dementias, music is a really energizing and engaging modality to get people singing and moving, and to really feel when the music is something you recognize, and especially something you love, it makes you feel like you belong where you are with that activity. So it got me really interested in working with older adults. And for most of I've actually worked in dementia care in a number of settings. So my very first job was in a skilled nursing facility, then adult daycare programs, HUD subsidized senior housing, and office on aging. And then for the last year and a half, I've worked as the education program manager at the Association for Frontotemporal Degeneration. We say AFTD, so we don't have to say all those words.
I'm saving it for you. I couldn't say it.
There we go. So AFTD, and we support people living with FTD, their family care partners. And I'll talk more about AFTD, but we're the leading voluntary health organization in the US focusing on FTD. So let me get to my slides. I'm going to share my screen.
Yeah, that's an impressive resume, Will. What instrument did you play when you did musical therapy?
So I actually studied guitar, which was not, well, my main instrument was piano and singing.
It's just hard to bring a piano around with you. So
yeah, I know it is hard to kind of drag that down the street and get it in the car and take it to that skilled nursing facility. So, but sometimes places have a piano, and that's helpful. And, you know, well-known songs are a big part of, like, people like to sing or hear things that they recognize. So that was a big part of my initial work.
Right.
So can you see my slides now?
Not yet. Nope.
Not yet. Okay. Well, that didn't work. Okay, well, hold on.
Sure.
Let me go back to here, and let me press share screen again and go here. Okay, you know what? I clicked on it, but I didn't press share.
Here you go.
So now you see my screen, and now I'm going to pull up my PowerPoint. There's so many clicks. To me, it's never intuitive. What about now?
Got it.
You see it
Okay.
wonderfully.
I'm going to move the three of you down to the lower right-hand side, so I won't see you making funny faces at me or anything, but I will stop along the way for questions. And so at that point, feel free to speak up and speak out. So frontotemporal degeneration, as it says here, is the most common dementia under 60. Now, most of us actually, in the US have probably heard of Alzheimer's disease and know a little bit about it. It is the most common cause of dementia, but typically it starts in the 70s, 80s, and 90s, sometimes in the 60s. And there is something called younger onset Alzheimer's, which starts before 65. But FTD, really the common or average time is in the 50s, 56 or 57, I believe. So it is an earlier starting dementia. And I'm going to talk more about that. This is my email and my phone number. People, if they have any questions who listen to the webinar, can certainly contact me, preferably by email, or they can always call our helpline, which I'll talk about towards the end of the program. So, I said we typically think of dementia as a disease of older adults, and often we think of people that have memory problems, confusion, may not be taking care of their personal care, and also essentially, since it occurs often in older adults, maybe have other health conditions, someone that walks with a cane or other difficulties. But in fact, FTD can look very different. So people, as I said, are symptoms start in their middle years, when they still are working. They might actually have children that live in the family home, a two-partner working household. They're paying off a mortgage, saving for retirement, paying for that University of Pennsylvania college education for a child who's in school. And so there's a lot of different life activities that are going on for people that are starting to show the symptoms. And that has a big impact on the family. And it also in some ways impacts the access to a diagnosis, but I'll detail that more in just a little bit. So today, in terms of the program, I'm really gonna describe how FTD differs from Alzheimer's disease, and then do a deeper dive on the spectrum of FTD diseases. And then finally, I'm gonna highlight how AFTD, the organization that I work for, the nonprofit, assists families that are living with FTD and provides information and education and resources for healthcare professionals. So just to get us all on the same page, dementia is not a specific disease, but it's a medical syndrome or a medical term that's really an umbrella under which a variety of disorders are in fact what's causing the dementia symptoms. So the symptoms, memory loss can be one of those symptoms, and it's a very common early symptom for people that are developing Alzheimer's disease. And when I say memory loss, it's more often short-term memory loss for someone with Alzheimer's disease, like forgetting a question they just asked, or forgetting that they had breakfast, or not remembering that their daughter visited them yesterday. So forgetting recent events.
Right. And not where you put like your keys, but things that you really should remember. So like you said, like a visit or where you're going while you're driving, those types of things.
Right, right. I mean, I don't know about you, but have a hectic day, busy day. I get up in the morning, I have a lot of to-dos, and I made myself a cup of coffee. I worked at home, and for the life of me, I sit down at my desk and it's like, well, where did I put my cup of coffee? So, but I have, fortunately, the ability to like backtrack and go back down to the kitchen and then say, well, it's not here. And then I go up to the bedroom where I, put on my clothes for the day, my virtual working clothes for the day. And then there it is, it's in the closet where I got something, the shirt that I was going to put on. So it means for normal aging and for all of us as we get older, forgetting things does not mean dementia, but it's the more global forgetting of specific things that, may have happened, or repeated questions like a husband who walks out to the kitchen to ask his wife about his cardiovascular appointment. He had a heart attack. He wants to know when it is. The wife tells him, and then 30 minutes later, he goes back in and asks about the cardiovascular appointment again. So that's short-term memory problems.
Okay.
That's going to be differentiated from FTD in just a moment.
Okay.
But these other types of dementia, Lewy body dementia, has similar symptoms to Parkinson's disease, but also there's an increased episodes of hallucination, very vivid visual hallucinations. So that's a common early symptom in Lewy body dementia. Vascular dementia, typically caused by a stroke or mini strokes or some type of cardiovascular blockage. And then mixed dementias, as you could guess, it means you have more than one, which is obviously not a good thing, but it's not as uncommon as we might think. And then finally, frontotemporal dementia. And again, these are changes in cognition. So memory is just one of them. It might be problems with thinking or planning or problem solving. It might be changes in personality or behavior. It could be changes in visual spatial understanding or interpretation. So any of these could be symptoms of a dementia. But now I'm going to talk a little bit more about FTD. So with FTD, as I've already said, it's much more common that the symptoms start under 60. And that isn't to say that people can't develop FTD later in life. And it's also true that FTD has been diagnosed in people in their 20s. So it's a wide range, but certainly the majority of people who develop FTD symptoms, we're talking about 50s into the 60s. And uniquely, memory loss is not an initial primary symptom. And in fact, memory remains intact for people even late into the disease. And that's because, let's say with Alzheimer's, the part of the brain, the hippocampus, where short-term memories, it's kind of like the filing cabinet of memory for the brain, that is one of the places where deterioration starts for someone with Alzheimer's, but it's not a part of the brain that's initially impacted with FTD. No surprise, frontotemporal degeneration starts in the frontal or temporal lobes, and I'll go into that in just a bit. Another contrast to Alzheimer's disease, so I think the Alzheimer's Association says there are more than 5 million people living with Alzheimer's in the US, 5.8 or something in that vicinity, and 45 to 50 million around the world. Well, with FTD in the US, we talk about 50 to 60,000 people, so it's much less common, but it's also underdiagnosed. And part of the challenge with that is people start showing symptoms so early that people aren't expecting a dementia. So a primary care doctor hears about changes in behavior or communication, and their first thought is not that they have a dementia, but some other disease. Mm-hmm. And for people with FTD, there's often a history of some kind of neurodegenerative condition like Alzheimer's or Parkinson's, or even a diagnosis of a psychiatric disorder that's part of the family history. And there can even be a genetic component that I will address shortly. So are there any questions so far from anyone about the disease?
Yeah, Will,
I'll just stop.
Yeah, sure. How do you figure out the different type of dementia that someone has?
So I do have a slide about diagnosis, but I'll talk about it here. So a comprehensive diagnosis for dementia would include a number of elements, a neurological exam. It often includes some kind of a brain scan, like a PET scan or an MRI. And
To see
that would
which
be,
region of the brain is
it shows you aspects of the brain. Well, a PET scan would typically show what part of the brain is impacted, sort of like a lighting up kind of scan, whereas an MRI will show an overall global picture of the brain and can show shrinkage or deterioration in certain areas. And that's key for frontotemporal degeneration, because frontotemporal degeneration, as a person progresses in the disease, will show atrophy or shrinkage in the frontal and or temporal lobes. But it includes a neurological exam. It includes a history from a family member, essentially a spouse or a child, that can really talk about what's different now in terms of cognition and behaviors as opposed to the way the person has been historically. There is no biomarker for FTD in clinical use, and there just now is established biomarkers for Alzheimer's disease in the research setting, that an amyloid PET scan, but that's not currently approved by Medicare for payment for diagnosis. So we still have a way to go with that.
Wow. Yeah, and I know we spoke about it briefly before we got started, that when I used to see younger people, and I was a social worker, younger people with dementia, it typically was Lewy body's dementia. I wasn't aware of the FTD types of dementia. So this is all really, really interesting stuff.
Helpful information. Yeah. Well, that is not that uncommon, John. I mean, I think even with healthcare professionals, they may have heard of FTD. And I must acknowledge that, I think I had shared with you, I've worked in the dementia care field for a long time, over 25 years. And I know that now that I work for AFTD, I have a much better understanding of FTD as differentiated from Alzheimer's. And part of it is that it's different in terms of when it starts, but it's also different in the symptoms. And I believe I'm going to get to that next. So I am going to quickly go over some of these things, because I think I've talked about a number of them. But I think one of the things that's critically important to kind of get an understanding of is that FTD is a spectrum of disorders. And I'm actually going to go into that in just a bit, where it's not a single disease, but a number of diseases that all start in the same region. So that's kind of different from Alzheimer's disease, which is a single disease that often starts in a certain part of the brain and is caused by amyloid, or the initial anomalies that cause brain deterioration are amyloid plaques and tau tangles. Do we know that that's the cause? I think we're still searching for what are the things that start any one of these dementias. So what's the target that we need to address to stop the deterioration? FTD affects, initially in terms of the disorders, either personality and behaviors, speech, or movement. And depending upon which are the initial symptoms is what type of FTD a person would be diagnosed with as part of a comprehensive diagnosis. Unfortunately, it takes on average about 3.6 years for a person with FTD to get a diagnosis. So that's a long time that a person living with the challenges and or their care partner is struggling with. What is this? How can we address these challenging symptoms? And what's effective in terms of if an inaccurate diagnosis of depression as the cause, why aren't depression medications working? So I'll address that later on in the presentation. Clearly, there's a large caregiver burden because not only the person with the disease, but also if they have a spouse or a partner or children who are caregiving, they have other responsibilities, potentially a job and children maybe to take care of. So that can be quite challenging.
So, Will, you had
Yes.
mentioned about taking 3.5 years or so to be diagnosed. And I know that I have come across people who have had trouble with the law, lose their jobs, have gone through divorce, have had lots of financial problems because they haven't been diagnosed, and they run into a lot of these issues, and there really is an explanation for it. And so it's nice that you're bringing this to the forefront, but it is a shame that people have to go through all of this first because of the fact they're under 60, so they probably are working and things like that.
Yeah. So a lot of the things, the tragic incidents that happen for people, especially with behavioral variant FTD, are things that are sort of like then become the warning sign that there's something going on here. You know, maybe it's shoplifting or it's assaultive behavior, getting in an argument with someone when in fact they never had that kind of personality before. It might be gambling away retirement funds when they never were someone that were usually gambling, or getting taken in by a scammer, sending life savings to a prince in Nigeria that needs money, the kind of scams that people with Alzheimer's may not have the competency to evaluate, but this younger person who is functioning in a lot of other ways, these challenges with impulse control or decision making or executive functioning are not noticed until something tragic occurs.
Mhm.
John, did you want to add something else or say something? Or shall I move
No, I mean,
on?
just from what Donna said, I mean, I never thought of that way. And then you have relationships and everything that are already ruined, and then people don't find out for years later that this was the reason why. You might have just thought the guy was a jerk, but it turned out that he actually had a medical problem.
Right.
How do we, if someone, like, say, for example, you had a family member or a friend who started having a lot of changes, how would you go about trying to identify them or push them towards getting some sort of testing done?
So first of all we really appreciate the opportunity to talk about this disease or these disorders, because a big challenge with behavioral variant FTD, which is about 50% of those with an FTD diagnosis, is that, you can't see it in the blood. There's no biomarker, and it doesn't show up on like the typical simple, mini mental status exam kind of test where people are asked memory problems or issues. It really requires a more extensive neurological exam, but they see the symptoms and the challenges.
The symptoms, like you had said, the first thing I would think is that they're on drugs or something. They're gambling things away. They're, stealing from friends or stealing from the store. I mean, it wouldn't even cross my mind to think dementia at someone in their 30s, 40s, even 50s.
Yeah,
I'm sorry.
Go ahead.
Sorry about that, Will.
So it's good that we've got a lot of lively conversation. So let's stay with it. Yes, Desiree.
I just wanted to say, it's just like in our society, anything that has to do with the brain or mental illness in any way, we're just, as a society, I really believe, just like touching upon all that. It's always like taboo, or like John said, you just think, this person, not so good of a person, not, they're this or that, but in reality, we just don't, truly know that they have this medical condition, and there's not enough, education around it. So, that's what we're here doing today. And I, hope to see more of it, but.
Yeah. Well, I would definitely agree with you. I think that behavioral health and behavioral problems, changes, and issues are an under-supported challenge in terms of our health needs. And I think it's at the core and at the heart of why people who are developing FTD symptoms are often sent off in different directions. So you know what, I'm going to actually, because of your interest in questions, I'm going to come back to some of these slides, but I'm going to actually go to this screen, and then I'm going to talk more about behavioral variant FTD and some of the symptoms, because I think that's an important aspect to really cover, because you're interested, and I think that the senior care group would be as well. So FTD, we call it frontotemporal degeneration. Some people call it frontotemporal dementia. People who are looking at the neurological deterioration can call it frontotemporal lobar degeneration. And then in the past, people called it Pick's disease. So you may have heard that terminology, but frontotemporal degeneration is where we have landed. So there are three sort of columns of functional change into which initial symptoms typically fall. And the biggest bucket or group of individuals is exhibit behavior and personality change, behavioral variant FTD or BVFTD. But there are also people who have deterioration in the frontal, but more specifically temporal lobe, that develop primary progressive aphasia, which is communication disorders related, or communication disorder related to frontotemporal degeneration. And then there's the movement disorders, corticobasal syndrome, progressive supranuclear palsy, and then sometimes, unfortunately, people develop both FTD and ALS, or amyotrophic lateral sclerosis. And in many individuals, there's a genetic component to that I'm not going to go into at the moment. But so there's a wide diversity of symptoms, but the most prominent one, and the symptoms that you were talking about, Donna and Desiree, are ones that I'm going to talk about now. So often an early symptom, a warning symptom that families notice, is a really strong representation of apathy. So a disinterest in activities or hobbies, in things that a person really took enjoyment in before, and they're no longer interested in it at all. Sometimes it's visually like they have no get up and go. I would say, a really rabid Phillies fan that like isn't interested in watching games and isn't excited about where the Phillies are, that kind of marked change or difference. And sometimes to some people, it might appear to be depression, but in a person with BVFTD, they don't exhibit sadness or grief. It's just that disinterest in activity or engagement. Another symptom can be disinhibited behavior. So that's when someone exhibits behavior which is not socially acceptable, such as, and again, it's really based on who they were, who they've been historically. So a daughter and her mother may be out at a restaurant, and a waitress passes, and the waitress is overweight, and her mother says, "Boy, that woman is really fat." And she says it loud enough that the waitress hears it, that other people in the restaurant hear it, or maybe someone using an ethnic slur when in the past they never would have said something like that. So it can be that their filter with things that they're thinking, they don't have the ability to control that impulse anymore, or in terms of disinhibited behavior may be a lack of awareness about personal space, or coming right up to people and talking to them even though you don't really know them, or inappropriate physical behavior such as hugging or kissing people that you don't know that well or you're not comfortable with. So deficits in executive functioning are the inability to plan or problem solve or organize multiple tasks in a particular order. I think that one's a little harder to suss out, but certainly families can see it and describe it. Loss of empathy. So what does that mean? Well, an example might be a father who has a daughter, and he was always, the love of his life, his daughter, raising her, is always interested in what she's up to and what she's about. She went off to college, and now actually, after graduating, she met the love of her life and has just become engaged. And she tells her father that, and the father is completely disinterested, doesn't say congratulations, doesn't say I'm excited for you, and in fact says, what's for dinner, honey? That there's this disconnect from the importance of what's happening in this person's life. So that would be one example of a loss of empathy or interest in the emotions of others. There can be changes in eating habits, such as gorging or only eating certain things. Sometimes it can be alcohol abuse, which was never a previous history for the person, but a very marked change in diet or eating. And then finally, compulsive or ritualistic behavior. So someone who's constantly picking at their skin or goes out to the mailbox every half hour, even though there isn't any mail, and that is an unusual behavior that started at this point in their life. So hopefully, and since many of these are warning signs or symptoms, to get a probable diagnosis, a neurological specialist, such as a behavioral neurologist or a neurologist or a neuropsychiatrist or a neuropsychologist or a geriatrician, would be able to look at these symptoms, either be observing them in an office interview or get a report from the family caregiver at that interview about these changes. And if they can confirm 3 of these symptoms plus a change in the frontal or temporal lobes on a brain scan, an MRI, then a neurological specialist can diagnose a probable cause of FTD.
I'd imagine, Will, that it would probably be hard to get the patient actually in the door. I mean, if they're having these behavioral issues, they might be reluctant to actually go to the doctors, even if their spouse or someone is asking them to.
So that is true. It's not unlike with Alzheimer's disease, where there's a portion of people with FTD that has something called anosognosia. So it's a lack of insight or awareness that there's something wrong or there are problems or issues. So it might involve multiple steps to get a person to a diagnosis, or possibly seeing a doctor or doctors for a diagnosis related to other things, but then having scans ordered and neurological exams. So it's certainly a complicated dance to getting a diagnosis. But the hardest thing is for families to get to that neurological specialist in the first place, because a person might be referred to a psychiatrist or psychologist who doesn't have any special expertise in FTD and is not an expert in neurological conditions.
Right. So they could spend a lot of time, years, maybe thinking it's depression because of the apathy or whatever. And like we talked about, their medicine's not working. And then it might click much later down the line where it would have benefited them if they were taken care of sooner.
Right, right. I mean, usually family members have to be very strong advocates that, this isn't working, or this doesn't make sense to me, or he's not grieving and sad. This depression medication isn't doing any good. And at some point, the family comes in contact with someone that determines that it might be a neurological condition.
Right.
So let me move on to the other types of FTD, because I don't want to give just BVFTD an overview. So there is also something called primary progressive aphasia. And this is when communication problems or challenges are the initial issues for a person where these changes are happening in the temporal lobe primarily. And there are 3 subtypes. I won't go into the specific details, but they are unique and different. Agrammatic non-fluent. There are issues with omitting words, like connecting words, or the verb tense of words. With a semantic variant, primary progressive aphasia, there's a difficulty with recalling or naming objects, and objects which are not complicated, like a pen or a watch, or struggling with words, and with logopenic, certainly difficulty with finding specific words or repeating phrases. And one thing about primary progressive aphasia is, because of the change in communication, the person might be more quickly referred to, let's say, a neurologist. There might be an assessment for a stroke or vascular dementia. And the final disorders of FTD are ones which impact movement: corticobasal syndrome, or CBS, progressive supranuclear palsy, and then, as I mentioned, FTD with ALS. So these 2 are initially often diagnosed as Parkinson's. They're called atypical Parkinson's, but the initial symptoms actually can be differentiated. With corticobasal, there's often a change in movement on only one side of the body, so asymmetrical muscle weakness, or uncontrolled muscle contraction. And progressive supranuclear palsy, there's often initial difficulty with vertical eye movement. So people, when presented with a visual scanning exercise, can only move their eyes so far up or down. So that's a prominent initial symptom. And finally, FTD ALS. There's an interest in these disorders because of the fact, a research interest, because there's often a genetic component when a person has both FTD and ALS, a genetic mutation that is caused by C9 or 72. And so there's active research in trying to find disease-altering treatments. So I'm going to stop. That was a lot of specific information, and I feel like I need a rest. Any comments or questions? I think it's clear why FTD can be confusing to people that think of as similar to Alzheimer's disease.
I was just going to say that was.
Go ahead.
Nope, go ahead, Donna. Sorry.
I was just trying to think of, like, where do families go for this kind of a diagnosis? Because a primary care physician might not catch any of this. And if they do suspect it, where should they go?
So first of all, we would definitely encourage, so I'm going to jump around in my slides again, because I feel like I want to go to some of the answers. And miss some of the other points. So sometimes families call AFTD. We are a nonprofit. We're an unbiased source of information. And so they will contact our helpline by info@theaftd.org via email, or by calling 866-507-7222. So maybe someone, or in their reading of symptoms, they're able to come up on Google with, these behavioral symptoms and younger onset, and they find out about us. So AFTD on our website, and if they call the helpline, can provide information to people about specialty neurology centers across the country that are knowledgeable about FTD. And so they're not everywhere. That's one opportunity or one resource. We also know that, as I said, family members have to be really strong advocates to say, this isn't the right diagnosis. I would like to get a referral to a behavioral neurologist or a neuropsychiatrist. Something is wrong here, and the medications for depression or bipolar disease are not cutting it. And in fact, sometimes people are misdiagnosed with Alzheimer's disease, and the commonly prescribed medications for Alzheimer's, such as Aricept and others, are also not generally effective and can even be contraindicated. So, if a person doesn't have memory issues, it's pretty unusual that they would have Alzheimer's disease. And some of these other more critical changes tend to come later in the person's disease.
I was going to say, I see it up on the screen there, but as far as support, if there's local support groups like there would be for Alzheimer's, a lot of people find, a lot of solace and a lot of information within those support groups that are in their communities, or could be virtual, because there are ways that, help the caregivers to figure out, that their loved one is displaying a lot of, these conditions and these signs and symptoms. So that's important to be able to offer, some support groups to people in the community for sure.
And one of the positive outcomes, if there could be any positive outcomes to COVID, was that the virtual world has become much more a part of our lives. There's telemedicine in some instances still being used, and AFTD really piloted using the virtual approach to support groups. We do have in-person support groups across the country, but not everywhere. We have virtual groups that are regional or national. We have some virtual groups for people with FTD. And so, yes, caregivers need to feel that they're not alone. And some FTD caregivers can get support and feel connected through a general dementia group, but it can be different. So we try to provide that opportunity for people to connect with other FTD caregivers, or people with the disease to connect to other people living with FTD. So that's the website location. People often call our helpline for that information, or people can, go to our caregiver resource page to get that information.
That's great, because like you said, it's such a difference in when someone's young and they have dementia and they're dealing with a family. They might have, young kids, a family they're supporting. And, dementia is terrible no matter what your age is. But if you're, say, a spouse of someone who has dementia at age 80 versus a spouse who has dementia age 50, they're going to have a lot of different problems, and it being such a small population that has this disease, it's great that they're able to connect it online, because 50,000 people spread out across the whole country, it's a small percentage. What's the likelihood that they're going to have something in your community that you can get to?
Especially if they're not in, close to a major metropolitan area, or definitely if they're in a more rural area, they would potentially have to go quite a ways to get to a support group. And so I know that not everyone is used to using virtual platforms. I mean, all of these virtual groups, people can also call in. So it's the telephone. It's still a lifeline in terms of hearing from others how they, adapt and problem solve and things like that. Before I have a feeling you're going to give me the hook pretty soon. So I want to just also mention that we have some very specific resources for healthcare professionals. So as you've mentioned, not everyone knows about FTD specifically, so that works in healthcare. So quarterly, we put out an e-publication called Partners in FTD Care. Our summer issue was all about facility-based care and how facilities can best prepare for a new resident with FTD, or adapt to and manage and prevent some of the challenging behaviors. We just last week sent out an e-publication for those who work in the clinical world in terms of primary care and others. What do families need after a diagnosis? We also offer we just started offering continuing education webinars. So on November 10th, our third continuing education webinar, which is free, offering CECs for social workers, nurses, and other healthcare professionals, will be live. You can find out about it here and register. And then the other thing down the road is on May 5th, we have a hybrid conference, both in person in St. Louis and virtual online. It is free. It's our AFTD annual conference. It's for families, persons with the disease, as well as healthcare professionals. And you can go to this website to sign up to get more information. People can get our Partners in Care and notifications of our webinars regularly by signing up for our professional mail list. We also have Help and Hope, which is a family newsletter that comes out once a week. I think that the one thing that I didn't talk about is that families who are impacted by FTD should always learn more about the genetics of FTD and determine whether it's something they want to pursue in terms of a genetic counselor session or even genetic testing. About 10% of familial caused FTD is caused by a genetic variation, an autosomal dominant cause of FTD. And so what that means is it can be inherited within a family from one of two parents to their children and so on. So
Will,
really,
is there any benefit, if you were diagnosed with it, if you had the markers that might make you more predispositioned to it, is there anything that you can do ahead of time to try to maybe slow down the process or anything like that? Or is it just that this is something to look out for?
So there's no currently approved or defined treatments that slow, prevent, or reverse the disease. So understanding your genetic status is helpful in a variety of ways to families. It's obviously a very upsetting and disturbing bit of news for a person to learn, either in themselves or from a parent. There's hope in research right now. So there is the opportunity. There are more and more research studies for people with a genetically caused FTD to get involved in. But of course, that's research and not treatment. It also can help in terms of learning more like family planning and issues around having children. What are there are ways to determine and make decisions about what's best for you and a partner or spouse from this point on.
Thank you. That answers my question. Thanks.
Sure. So I think I've maybe talked long enough. I don't know. Have we covered it?
Yeah, no, that's been great. Yeah. This is a lot of great information. I hope more people, tune in, they listen to it, and they learn more. And if they have questions, they'll reach out to you.
Sure.
Yeah.
I was also happy to see that you were offering the CEUs, because with more of, nurses and social workers in the field, the more they have access to the information, and, they're getting that, that CE with it as well. And it's free. I mean, that's a great route to go down. So we can surely share all that information too, as we will share this video today. So that was great.
Yeah. So I will go ahead and assume, Desiree, I can share the e-notice about that as well as the flyer. I'll send that to you separately, but so glad that your audience will be keying into that. So this is the third CEC that we're offering. We're going to continue to offer that. There are a couple other programs about BVFTD and primary progressive aphasia that are recorded. They're not available currently for credit, but the information was credit approved. So it's that caliber and quality of information. And then coming in the new year, we're going to be offering more programs, including we're working on a continuing medical education program for primary care doctors about FTD to help speed up an earlier diagnosis. And that will probably be available to nurses and social workers as well. So I'll keep you in the loop about that. Thank you all so much. And for the work that you and your colleagues do to support older adults and people with different types of dementias and chronic illnesses. So appreciate it.
Thank you so much. I know that Rothkopf Law Group really does appreciate having a partnership with you guys, and would like to mention that any of your families would certainly benefit from not just our elder law firm, but many across the country should really probably do that and get a consultation with an elder law attorney.
And that is so critically important. So in that what do families need most issue that we just sent out last week, legal and financial issues are pivotal and critical early on, because with FTD, as we spoke, many things can happen which really impact the financial safety and health of a family. And so we do recommend that families reach out to find an elder law attorney. So thank you for highlighting that. So
thank you, Will.
Great. Well, Will Reiter, thank you so much for sharing this information. This has been great. One more time, I guess, if you don't mind sharing your contact info. I know you said your email. Sure.
My email is wreiter@theaftd.org. wreiter@theaftd.org. And if people want to call our helpline, it's 1-866-507-7222, or email the helpline at info@theaftd.org. And make sure you check out our website. There's so much more than I actually talked about. Respite grants for families, along with support groups. That's another hot item in terms of families knowing about respite and quality of life grants for those that are living with FTD. So thank you very much.
Cool. Thanks so much.
Thanks, Will. We appreciate it. Thank you.
Take care.
You, Will.